Welcome back to the Neuroblastoma Parent Global Symposium 2021. My name's still Nick Bird, and I'm going to be moderating this session on advances in immunotherapy for relapse refractory neuroblastoma. Today we're being joined by Dr. Jaume Mora, Pediatric Oncologist and Scientific Director of Oncology and Hematology Area at St. Jaume de Diu, Barcelona Children's Hospital. Dr. Rajen Mody, Professor of Pediatric Oncology and Hematology at CS Mott Children's Hospital, University of Michigan Health, and Dr. Robbie Majzner, Assistant Professor of Pediatrics in the Division of Hematology and Oncology at Lucile Packard Children's Hospital. If I'd like to draw your attention again to the panel to the right of your screen where you can submit questions, and there's an option to do so anonymously if you choose. Questions will be addressed after all the presentations have concluded. And with that, I will hand over to Dr. Mora for updates on Naxitamab and Omburtamab.
Hello, everybody. My name is Jaume Mora, and I'm a pediatric oncologist practicing in Barcelona. Thanks the organizers once again for inviting me to participate in this very important meeting, now expanding worldwide. It is a pleasure for me to share with you the most recent updates on Naxitamab and Omburtamab for the treatment of refractory and resistant neuroblastoma. So I want to remind all the audience today that Naxitamab, among the other antibodies, Anti-GD2 antibodies that are in clinical use nowadays in many parts of the world, but not everywhere, it's humanized antibody, and as opposed to the chimeric antibodies, it's a much more potent antibody that was developed more recently. So we're talking about the second generation of anti-GD2 antibodies. So we're going to be talking today and reviewing very quickly the activity of these next generation of antibodies, as well as the combinations of them. Just a historical reminder to everybody, because the history for Naxitamab has been really puzzling. It was first developed by Dr. Chang in New York and first published in 2012. And soon after, Y-mAbs Therapeutics company was created in 2014. And the trials that were performed both in New York as well as internationally led to a very quick, very fast, relatively fast FDA approval at the end of last year, actually a year from now in the US approved and known as Danyelza. So this is a really fast track approval for any drug, and even more so for pediatric oncology, for the pediatric oncology field. So what have we done, and what can we offer our patients nowadays in Barcelona through Y-mAbs Therapeutics? To remind everybody that Naxitamab was first ever infused in our center June 12, 2017. Since then, we've learned quite a lot, and I'm going to summarize to begin with our experience for patients coming to our institution, and after getting induction therapy, meaning chemotherapy and surgery, and once evaluated and found to be in complete remission, meaning no evidence of disease, then those patients would go on to either the 2002 trial nowadays in different parts of the world, or through compassionate use in our center to be treated with Naxitamab antibody. For patients who were not found to be in complete remission, and they showed partial remission or refractory disease in the bone and bone marrow compartment, then they would go on to the 201 trial, which I'm going to summarize the data later on. For patients who were found to be in progressive disease, those patients would go on to receive some more rescue chemotherapy until disease stabilization, and then they move on to antibody-based rescue treatments. A reminder also to everybody in the audience is the difference, another major difference of naxitamab as compared to the chimeric antibodies is that this is mainly an outpatient treatment. The schema is fairly well known, but I'm going to summarize very quickly. It's a 10 days subcutaneous GM-CSF. First 5 days given by the parents at 250 micrograms per meter square per day. And then followed by 5 more days at double the dose, 500 micrograms per meter square, together or along with 3 doses of humanized 3F8 or naxitamab at 3 milligrams per kg per day per dose, 3 times per cycle, which is a total of 9 milligrams per kg, which also comes up to a 270 milligrams per meter square, which is a much higher dose of antibody per cycle as compared to the dinutuximab-based therapies. So for patients who were found in complete remission once they got to our institution after being thoroughly evaluated with 4 bone marrow aspirates and 2 biopsies, MIBG, and or PET FDG, and whole body MRI, if those patients were with no evidence of disease since June 2017 up until August 2020, we treated 73 patients. 55 were found to be in first complete remission, 18 in second complete remission after a prior relapse. So this is what we're talking about, a patient coming in with an MIBG completely negative with a Curie score of 0. We also perform a whole body MRI, which I'm going to be talking later on, because we've learned and reported very interesting observations that can be taken out of the MRI characteristics of the lesions in the bone as well in the soft tissue compartment that we use to evaluate thoroughly the status of the disease. Anyhow, out of the 73 patients, 22% or 16 did not complete treatment. Why? Well, 5 because of grade 4 toxicity, meaning important toxicity. 1 because it developed blocking antibodies, and 10 because actually they relapse. They were in complete remission and they relapse through the planned treatment of 5 cycles. So 6 out of the 55 who came in first remission, 4 out of the 18 in second complete remission. The relevant toxicities, grade 4, that I mentioned includes 3 patients with apnea related to the infusion of the antibody, 1 opioid-related chest rigidity syndrome, and 1 patient who developed a stroke, which we are not sure whether it was related to the antibody, but it had to be taken off the study. We recently reported the results of this study, and as you can see, we're reporting 2-year event-free survival for all the population of 74%. Need to emphasize that we include first complete remission as well as second complete remission. Certainly, event-free survival, it's really low. So again, a very big difference in overall survival as compared to this is event-free survival for both, for first CR, 74%, and second CR patient, 38%. So here I'm showing you the very important difference between patients who had a prior relapse or not. So again, multi-variable analysis of survival, only the history of a prior relapse correlated with or predicted event-free survival, not overall survival. As you can see here, both groups had a similar overall survival above 84%. So then the question of high-dose chemotherapy and transplant always comes up in our experience as has already been discussed in the meeting and that we had already discussed in other forums, like recently in SIO. But I'm just summarize the two studies of, in our experience of patients, as I said, coming into our institution to receive Naxitamab-based immunotherapy or dinutuximab in the past, who had who had received prior high-dose chemotherapy and transplant or not. So when we compared both groups in red or in black, we did not see any difference in overall survival, neither in event-free survival. So in our experience, there was no difference between these two populations. Again, another interesting finding is when we compared the 2-year event-free survival or overall survival outcomes reported on the landmark study by COG for patients, remember, receiving dinutuximab post autologous high-dose chemotherapy and transplant. They reported 63% for a patient receiving immunotherapy, significantly compared to the non-receiving antibody therapy. But we're reporting without any high-dose chemotherapy and transplant, very similar results at 2 years, and an overall survival they're also very similar. So in our experience for first CR patients using Naxitamab, we certainly do not need high-dose chemotherapy and transplant prior to achieve similar or even better outcomes. The treatment, as I said, it is as an outpatient in 30 minutes, which actually really increases and improves the quality of life of the patients and families as reported. The overall need for opioids and analgesics is 7 times less in our experience for patients who received dinutuximab in prior and the same patient receiving Naxitamab in the next cycle of treatment. Toxicity that we're going to be talking about these includes specifically hypertension and PRES in the Naxitamab group, and issues about availability and price is still out there for discussion. So what about patient who comes into our institution and is found not to be in complete remission? Patients are called either primary refractory or secondary refractory. So those patients, as you all know, have a very poor outcome reported by different groups and discussed in this meeting as well, with salvage chemotherapy, with MIBG therapy, including, and all the trials from ITCC or SIOPEN for these refractory disease patients are only reporting PFS and overall survival that do not exceed the 2 years. So we're talking about a very difficult group of patients to treat. So again, this is the schema: patients coming in, having received induction chemotherapy and surgery and found to be with persistent disease. Then we treat those patients with anti-GD2 immunotherapy or Naxitamab. This is an example: patient coming in after receiving induction treatment and found to be, have residual disease in the bone, in many bones actually, as you can see in this MIBG with a Curie score of 18. This patient received Naxitamab-based immunotherapy only, and after 2 cycles, we see many sites of disease gone, disappearing, but some remaining with a Curie score going down to 6. Some of the residual lesions can be highlighted here in the vertebral body, for instance. With 3 more cycles, after completing 5 cycles, all the bone lesions are gone, and this is really rewarding. This is really amazing to see for this very refractory, chemo-refractory disease with a Curie score of 0. So this is the summary now of the 201 trial, which I said it's specifically designed for patients with primary refractory disease in the bone and or bone marrow compartment only. And why is that? Well, the reason is because we know for the longest time with anti-GD2 immunotherapy that antibodies alone do not work really well on the soft tissue masses. Later on, we will talk about chemoimmunotherapy, and Dr. Mody will also expand the experience with these combinations, specifically for the soft tissue. So antibody alone for rescuing bone and bone marrow disease. So we already mentioned this is what it's called refractory disease, even in patients who had prior relapse and became resistant. So all these patients, again, were fully evaluated, as I already mentioned. And I'm describing the 48 patients enrolled in the trial, that data that was used for the FDA evaluation and approval. So this is the summary of the characteristics of the patients. Majority stage 4s, as you know, bone marrow. Majority had bone and bone marrow disease together. Half patients had refractory disease, about half had relapse disease. This is basically the response rate, which was the primary endpoint of the trial, with an objective response rate evaluated by an independent committee of radiologists and pathologists from the data that was submitted from the different international sites involved in the study. We are reporting 58% of objective response, meaning either partial response or complete response, which is basically here 44% in complete remission, like the example I showed you, or 14% showing partial response. Progressive disease also shown in 5 cases among those 48 patients in the trial. Sorry, this is the median duration of the response. So patient had about, from the 36 patients with enough follow-up, we have a median duration of response of about 24 weeks so it's about 6 months of median duration of response. So the summary of the secondary effects in this trial, clearly along the lines with all the class effect for anti-GD2 antibodies, vast majority of patients showing hypotension, pain, almost universal, urticaria type of reactions, fever, bronchospasms, tachycardia, so on and so forth. Fortunately, all of them transient. 4 patients had to be discontinued for treatment because of anaphylactic reactions, respiratory depression, 1 urticaria, and 1 severe hypotension. But the rest of the patients did complete the treatment as expected, and none of the patients showed any fatal events, nor transverse myelitis or PRES as reported by the other antibodies. These are the type of reactions that we see during infusions, the allergic type of reactions, skin rashes because of the expression of GD2 in the melanocytes and in the skin and some dermal cells. Also, as I said, very similar to all the anti-GD2 antibodies. Serious adverse events, bronchospasm, hypotension, unresponsiveness, apnea, all these, it's well known. Fortunately, all reversible, and with a skilled team of nursing and physicians, those can be really managed in the outpatient setting. Certainly, pain has been, it is a major side effect in all the anti-GD2 antibodies, and we have developed, together with our anesthesiologist, a ketamine-based protocol that prevents all the opioids in order to improve the tolerability of the treatment. So in conclusion, Naxitamab provides a clinically meaningful response in high-risk refractory disease in the bone and bone marrow setting that provides hopeful potential for very refractory patients like the one that I'm showing you here. First CR in 2015, patient relapse in 2019 with massive relapse, and on Naxitamab got into second complete remission again in a year later. So real hope for relapse refractory patients to become in CR again through Naxitamab-based immunotherapy. So I'm going to go really briefly through the combinations of anti-GD2 immunotherapy and chemotherapy through the HITS trial that we are collecting now the whole data. This is the analysis that we have already presented at SIOP last year. This combination, it's also following the Rajen Mody's initial description from COG. But we are combining Naxitamab and GM-CSF together with irinotecan and Timodar. These are the differences. This is a much heavier dosing for temozolomide and other slight differences, but similar and higher doses of antibody, as I said. We've treated in our center 55 patients, 48 evaluable, with very difficult to treat patients, patients who had already received antibody alone and did not respond. Also, majority of patients had already received the same irinotecan combination as opposed to the COG trial, and even that, we are reporting 40% objective responses, which is similar rate of responses that the COG has already shown. A very clear example of 2 cycles of HITS on a massive MIBG positive disease, all the bones in the skeleton of this patient going into complete CR, amazingly, having not responded prior to Naxitamab only, but with the combination therapy, this patient got into complete remission with only 2 cycles. This is an amazing response that is really hopeful for the future. So chemoimmunotherapy, certainly something to consider, that now we are exploring other chemotherapeutic agents. We are combining ICE with Naxitamab as well as cyclotopo with Naxitamab. So many different options for future to be looking after. I'm going to just point out something that we recently reported. Patients treated with these new combinations of antibody-based therapy also have a very interesting, some of them have a very interesting evolution that needs to be highlighted. So we reported these 14 cases that, like this one, I have fully evaluated by all the imaging techniques. As you can see here, massive MIBG positive lesions in the whole skeleton, also evaluated by the whole body MRI, coincident lesions described by these MRI characteristics, femur lesions all throughout, some of them positive on MIBG. Well, so we've seen patients becoming very stable, non-active disease, but persistent MIBG positive. Those patients had a PET, FDG PET, which turned negative, and the MRI characteristics, like the one showing here, did not show any signs of activity with a non-restrictive ADC. So we serially biopsied all these lesions, showing clear histopathological definition of mature disease or ganglioneuroma. So look after all these very persistent cases that we would evaluate as a stable disease using classical evaluation systems, but indeed they are evolving into a mature disease that is hopefully non-progressing or potentially curative in the future. Just very briefly regarding Omburtamab. So this is the CNS relapse, central nervous system relapse, which is a devastating disease, well known, described by the Memorial Group, to be able to be managed successfully with this multimodality approach, including surgery, chemotherapy, as well as craniospinal RT, and including immunotherapy with antibody, Omburtamab in this case, which is anti-B7H3 or CD276, now named Omburtamab. And through YMAPS as well, we are running an international trial to reproduce the data that Memorial Group initially reported of 50% long-term survivors for this particular child. This is a patient of mine with isolated CNS relapse, which underwent the whole program of rescue treatment, and certainly the hope that we are going to be able to reproduce this data and provide hope for this CNS relapse patient. It's really out there. The treatment is also outpatient. The infusion of the antibody is very well tolerated. We are aiming for two infusions, 2 doses of Omburtamab, separated out by several weeks. We've treated over 20 patients in the trial, and now FDA is evaluating. This is the first patient we treated back in 2019, and this is the patient of mine that I showed you 3 years later. This patient remains in complete remission, hopefully in the long-term survival and cure. So in my final conclusion, sorry I've been delayed. Anti-GD2 immunotherapy, certainly we know is not passive. Event-free survival is no longer a surrogate marker for overall survival, so we should be aiming for all the trials to report for overall survival, meaning there is cure beyond first-line therapy or relapse, and this is really a hope to be transmitted to all the parents in the audience. More potently designed antibodies can cure more patients, and certainly combination strategies are already here to be used. Many combinations are being tested that are certainly going to provide better chances of cure. And I cannot stop by saying that you guys, parents, have changed the course of the disease, and YMABS is an extraordinary example of this as well. So my thanks also for all my staff at Sant Joan de Déu in Barcelona, who has made an extraordinary effort to change the lives of many patients all around the world. Thanks for your attention.
Thank you, Dr. Mora, for that super informative presentation. Next, I'm going to hand over to Dr. Mody to present chemo-immunotherapy combinations. The floor is yours, Dr. Mody.
Okay, can you see my slides, Nick?
Yep. I can see the screen.
Full screen, let's see.
Yep.
Yeah, so once so full screen, I can't see the chat or anything, so if somebody can monitor that, please. Thank you, Nick, and all the organizers for having me. Last time I talked was 2018, and since that time, I think our world has changed literally and figuratively. So looking forward to coming back when we are all a little bit more normal world. So today, my mandate is to talk about chemo-immunotherapy combination in USA and North America for high-risk neuroblastoma. And I'm going to talk about some of my studies as well as other COG studies and the St. Jude studies in America, which are currently ongoing or has recently been completed. It says disclosure, I serve as a data safety monitoring committee member for YMAB Therapeutics for their clinical trials 201, 203, and 701, some of which we talked about. So, and before I start on chemoimmunotherapy, I just wanted to kind of take a minute to talk about how the role of immunotherapy came about. And since this was just discussed in the previous talk, I would just probably keep it very brief that originally when the chimeric antibody was first used, there was a strong belief that it actually works better if you treat it in minimal residual disease setting. And if you use it with chemotherapy, it might diminish its ADCC, antibody-dependent cellular cytotoxicity. And so it should better be given with just cytokines and not with chemotherapy. And the role of those immunotherapy would be to prevent relapse. And this Kaplan-Meier curve fever shows that when this was given in a minimal residual setting after chemotherapy, transplant, and surgery and radiation, it actually improved the event-free survival and overall survival in a statistically significant manner, leading to FDA approval of Naxitamab in 2015. In the same trial, LSU and colleague noted that there were very small number of patients who actually had minimal active disease, which was biopsy proven, post-radiation. And when they did their survival analysis, they found that 1/3 of those patients actually had long-term survival, and over half of them have a prolonged overall survival, indicating that antibody alone with cytokines did have some activity against active disease. This was the kind of inception of our thought process that maybe it should be combined with some chemotherapy to see in a refractory setting. And that was the rationale when we were talking about the chemoimmunotherapy first trial design in COG in 2012 to 14 era, that we had noticed some activity as a single agent in some patients in Alice use study. We had seen Alice had run another pediatric oncology study, that we also noticed that there were some responder with not only bone disease, but actually soft tissue diseases as well. There were other trials, including from the Sloan group, as well as other humanized antibody and the CHO-1418 antibody, that there were some responses to bone disease as well as soft tissue masses when the antibody was used alone. And when we looked at the lymphoma literature using rituximab with chemotherapy and breast cancer literature using Herceptin with chemotherapy, and looking at some of the data from the 0032, we finally decided to combine in our first chemoimmunotherapy trial for relapse, refractory, and progressive neuroblastoma. And unlike some of the other studies that Jaume talked about, these are all comers with relapse, refractory, and high-risk disease and progressive disease, which also has not only bone disease and bone marrow disease, but they also have large soft tissue masses. And this trial was actually opened initially as a randomized trial, comparing it to temsirolimus when it's given with a common backbone of irinotecan and temozolomide. And ultimately, everyone knows that this trial was highly successful in favor of immunotherapy, and dinutuximab arm, which is shown in green here, became a winner. Trial was closed early and opened as an expanded single-arm trial, and it was completed as a single-arm expanded cohort of total of 53 patients, out of which 51 actually received therapy. And I think this actually just shows the response rate of CR and PR of about 42% in highly refractory patients with solid tumor as well as bone and bone marrow disease of 42%. Another 42% has prolonged stable disease. And this really led to a lot of excitement in the oncology community, and ultimately led to development of several other trials in the upfront setting that we will talk about. Now, before we go to that, just wanted to look at some of the things from the parent's perspective, like when a patient responds on a study, like what does that mean in terms of their outcomes? Because having early response has been shown to be a best predictor for long-term survival, but is that really true for a relapse setting? So as you can see in this Kaplan-Meier curve here, there are like 3 graphs almost overlapping with each other shown, but the one to focus was the green dotted line, which is at the combined cohort, which shows that about 35% of the patient at 3 years were still in remission after the chemoimmunotherapy ANBL trial, and almost 60% of patients were alive, and overall survival was around 57 to 60% at 3 years, suggesting that this was almost double the historical data, what we have seen when a patient is treated with chemoimmunotherapy versus the other targeted agents and MIBG therapy. And in order to compare that, what I did was looking at a very nice publication that was done by our COG group led by Wendy London, our ACE statistician. She actually looked at, on the left, you see the survival curve for a historical. Again, I just want to acknowledge and say these are not apple-to-apple comparison, because this was historical data of about 280 patients from 2002 to 2009, and about 100 patients from 2009 to 2014, when they were treated with COG phase 1 and 2 trials. Majority of them were actually first relapsing, but there were some second relapses, and only 13% of these patients had received any form of antibody. And when you compare that to the overall survival of ANBL-1221. So 4-year overall survival historically has been 20% or less compared to close to 60% in ANBL-1221. So clear, almost tripling. Again, want to warn people not to conclude too much from this. This is historical comparison, which is notorious for all sorts of biases, and they were not exactly the same patient population. But nonetheless, it does show that patients who were treated on ANBL-1221 had definitely higher overall survival compared to historical published data. One of the things leading to this is a lot of anecdotal. The publication is being finalized. A lot of patients in North America being treated with ANBL-1221 like treatment, even when they progressed on ANBL-1221 with dinutuximab with a different chemotherapy for second, third, sometimes fourth time, and many of the patients responding, really leading to a prolonged overall survival in this patient population. So that has been a relatively a new paradigm in a chemoimmunotherapy world compared to many of the biologics chemotherapy, and to some extent in MIBG, where you don't use the same agents once or twice. Antibody has been used with a different chemotherapy for second, third, and fourth time, with responses leading to increased overall survival of these patients. So based on this data, since this trial was so effective in relapse refractory population, St. Jude's actually had their single institution phase 2 trial led by Wayne Furman and Sarah Federico, which was published in Clinical Cancer Research recently. It was a single arm, 2-stage study using chemotherapy backbone, which was very similar to the COG backbone, but it was combined with a humanized 1418 antibody with a specific mutation which does not allow complement activation to reduce the pain. Pain is supposed to be believed to be more because of the complement activation, and this mutation reduces complement activation or prevents it with reduced pain. And that's a St. Jude's antibody, different than the one that was talked about in the previous talk. And this was given in newly diagnosed high-risk patients, 6 courses of chemo with St. Jude's humanized antibody, along with cytokines, followed by European backbone for transplant with blue-sulfan malphilan compared to the carboetoposide backbone used by COG. And patients also received additional courses of St. Jude's antibody with KIR ligand mismatch natural killer cell for parents when available, followed by the 5 cycles of antibody with cytokines. And the results were very encouraging. These were 42 patients, high-risk patients treated. And as you can see, 76% of those patients had partial response after just 2 cycles, and 95% has CR or PR after end of induction. Tumor volume decreased from 76% to 100%, and of 35 patients with stage 4 disease, 31 had a Curie score of 2 or less at the end of induction, which is a fantastic response. No patient progressed during induction compared to the traditional chemo backbone, where about historically has been shown to be about 14 to 15% of those patients progressed during induction. And this chemoimmunotherapy was very well tolerated. 3 patients had HAHA antibodies, no mortality related to the humanized antibody administration during induction or in the maintenance. And if you compare what the authors did in this publication, they compared their response rates after 2 cycles to the NBL-02P1, the COG backbone without antibody. And so this is 76% versus 40% of patients responded after 2 cycles, chemo versus chemoimmunotherapy. And then at the end of induction, the response rate for chemoimmunotherapy was 95% to 87% with just chemotherapy only. This is a waterfall plot just showing the tumor reduction, and you can just see this is the median reduction, and it just shows with each patient the longer the bar graph on the downward direction, the more tumor shrinkage, and only one patient had 5% progression, which still didn't meet the criteria for progressive disease. And as you can see, the Kaplan-Meier curve for this, a 2-year event-free survival was 85, and overall survival was 95%. So clearly, very, very encouraging results from this single institution study. And so the author wanted to compare how does it stand compared to chemotherapy only. And so this is for they compared the similar patient population and chemo regimen, the difference between the St. Jude study and the previous COG study, which was published by Alice Yu and Julie Park, that these were similar patients with the difference of that St. Jude's gave humanized antibody therapy with induction and during consolidation and post-consolidation. The transplant prep regimen was the European Blue Mel regimen compared to the COG regimen of CEP, and one additional course of humanized antibody with NK cells were given when available in about 27 patients. And as you can see, the difference 2-year EFS of chemoimmunotherapy in the single institution St. Jude's study was 85%, which is a fantastic result compared to 66% for the COG study, and overall survival was 95% compared to 86% for the COG study. So again, these are initial studies, single institution studies, so we have to be careful. We cannot extrapolate this for a national COG data, but these are very encouraging results. And based on this, a multi-institution pilot was run, which I'll talk about in a minute, and then a COG is planned to do a randomized trial of chemotherapy versus chemotherapy with dinutuximab beta during induction in high-risk neuroblastoma patients. And based on these 2 previous successful studies, the one ANBL 1221 and the St. Jude studies, there are several follow-up studies are open at the COG in North America. ANBL 821 is led by Meg Macy and Kelly Goldsmith, and this is a phase 2 randomized study of irinotecan dinutuximab versus IT-DIN with DFMO for children with first refractory, relapsed, or progressive neuroblastoma for both bone marrow and bone disease as well as soft tissue tumors. 1821 opened in May of 2019. Unfortunately, had a lot of hearing toxicity, which is a known complication of DFMO, and the study was stopped, was amended and opened with an intermittent schedule of DFMO, and so far so good, and the study is progressing nicely with 40 out of 95 patients have been enrolled, awaiting results. The second study was led by Sarah Federico and is a follow-up of the St. Jude study. And based on the St. Jude's data, COG ran a limited institution, 12 institution pilot using chimeric antibody dinutuximab with GM-CSF for newly diagnosed high-risk patients during induction. And this study has now closed, enrolling 42 patients, and the study was very well tolerated, and this was mostly a feasibility and safety pilot, and it has accomplished its goal. And based on this, COG is currently planning its next upfront high-risk neuroblastoma trial, which is going to randomize, as I said, chemotherapy arm to chemoimmunotherapy arm. And the final study, which is open at COG, is led by Amit Desai and ANBL 19P1, a pilot study of dinutuximab and irinotecan temozolomide in post-consolidation. So using the same ANBL 1221 cassette, and instead of just using antibody, using chemo and antibody combination. And this study has just been opened, and eight of the subjects has been enrolled. The patient has tolerated the therapy very, very well. And just to summarize the chemoimmunotherapy studies at COG and in America, chemoimmunotherapy combination has been very well tolerated, both in the relapse refractory setting, as well as with newly diagnosed patient with bone marrow disease, as well as with soft tissue masses. And when used in relapse refractory population, just like in ANBL 1221, it resulted in better overall response rate, event-free survival, and overall survival when compared to non-immunotherapy containing regimen historically. when it was used as a single institution at St. Jude's in a chemoimmunotherapy setting, the St. Jude study showed better response rate at the end of induction, 2-year EFS, and overall survival compared to the chemotherapy historical regimen ran by COG. Again, it's only 2-year follow-up. It's a single institution data, so we have to be very careful in interpreting data. And to really validate this data, COG, again, as I said, is going to run a randomized trial in all COG 250 centers, and that study will be open soon. Finally, this anti-GD therapy and chemotherapy combination is toxic, and so it is very important to really identify the biomarkers which are predictive of response to or lack thereof. And so our group, Robbie's group, as well as Alice, Paul Sondal, and nationwide, several of these labs are active in doing, and John Maris and Yael's group doing several studies on tumor and peripheral blood, trying to identify biomarkers. And the studies done on tumors include DNA and RNA sequencing, including single cell and spatial sequencing, tumor microenvironment analysis, including TNK and macrophage analysis, and GD2 staining, whether this GD2 staining is predictive of response, and peripheral blood studies looking at immune profiling, RNA-seq, NK cell, and macrophage analysis, as well as looking at Fc gamma receptor polymorphism, as well as KIR ligand genotyping, whether that is predictive of responses along with the GD2 level. I think that's my last slide, and I want to thank the organizer for having me virtually. And be happy to take any questions now or in the forum. Thank you.
Thank you, Dr. Mody. We're going to take questions once all the talks are completed. So if you'll just stay with us, thank you for that lovely talk on all things chemoimmunotherapy with Unituxin and the St. Jude antibody. So finally, last but by no means least, I'm going to invite Dr. Majzner for a talk about Anti-GD2 and Anti-CD47. Over to you, Robbie.
Thanks, Nick, and thank you to the organizers for inviting me to share some of our research today. My name's Robbie Majzner. I'm at Stanford, and I'm going to talk about a combination of GD2 and a macrophage checkpoint antibody called anti-CD47. These are my disclosures. They're not relevant to what I'm going to speak about today. So I'll just give a short rationale for why we think it might be a good idea to treat macrophages in pediatric cancers, some background on how anti-CD47 works, and then our combination of anti-GD2 and anti-CD47. So checkpoint inhibition with anti-PD-1 has obviously revolutionized immunotherapy for adult oncologists. If you talk about immunotherapy with an adult oncologist, they only think about checkpoint inhibitors. They don't think about anti-GD2 antibody, and they don't think about CAR T cells mostly. They just think about checkpoint inhibitors because for adult solid tumors, it's really just changed the landscape. Unfortunately, it hasn't been the same story in pediatrics. This was work when we looked at about 400 tumors and found very low expression of the ligand for PD-1, PD-L1 in these sarcomas, medulloblastoma. It's also infrequently expressed in neuroblastoma. But with the success in adult oncology, there was a strong push to get several of these agents, nivolumab, pembrolizumab, and atezo into phase 1 trials in children. And unfortunately, as single agents, they really haven't had the activity that we hoped for in any of the kind of common pediatric sarcomas or in neuroblastoma. Now, that's not to say there's no role for them in combination, but their major mechanism of action is really to unleash the native T cells that are there to respond to mutations in the tumor. And as we know, pediatric tumors just have way lower levels of mutations. In many patients, we find no mutations, or we just find epigenetic alterations that drive the cancer. So we don't really, the T cells don't really have something to respond to. And in line with that, when investigators have compared adult tumors, seen here on the left, with pediatric tumors, they've seen much lower levels of CD3, this is T cells, on those slides. So there's less T cells in pediatric tumors. But at the same time, they found that there's more macrophages there, This is a CD68. This is a marker for macrophages. And basically what this slide tells you is just that pediatric tumors are chock full of macrophages, and we've always known they've been there. We think they're there. They have an immune inhibitory role, but we really don't know for sure. Or they're just there because the tumors are rapidly growing and they basically like to eat dead tissue. So we don't fully understand why we're there. Now, the story of anti-CD47 comes out of Irv Weissman's lab at Stanford, where they discovered that CD47 is expressed by tumor cells and also many normal tissues. And it's basically this checkpoint against macrophage activity. So macrophages do something called phagocytosis, which basically means they eat the tumor cells. And this checkpoint basically stops, it tells the macrophages, don't eat me. So they called it a don't eat me signal. They also made the first antibody blocking CD47. And when you block that axis, the macrophage then eats the tumor cell. Now, as I mentioned, tumor cells express CD47, but so do normal tissues. And so if a macrophage, if you gave an anti-CD47 antibody to a patient, you would be afraid, oh, now the macrophages would eat everything. They would eat your normal blood cells, they would eat heart cells, etc. But actually, the decision for a macrophage to phagocytose, to eat the tumor cell or not eat the tumor cell, is really about a balance between eat me signals and don't eat me signals. And there's this one eat me signal that I'll talk about a little later called calreticulin, which comes up to the surface on tumor cells when they're basically ready to be removed by the immune system. And normal tissues don't express high levels of calreticulin or other eat me signals unless they're under stress. So we see calreticulin, high levels of calreticulin on heart cells after a heart attack, for instance. And so it's really the body's way of removing cells. So when you think about a macrophage's decision to eat the tumor cell or not, it's really a balance of these don't eat me signals on the left, so the CD47 signal, and then these pro-phagocytic, these eat me signals on the right. So we talked about calreticulin, but then also an antibody like dinutuximab or naxitamab has an FC region, a piece of the antibody that engages the macrophages and says, come here, I'm tasty, come and eat me. Let's skip to this slide first. So I was at ASCO one year and saw a talk that turned into this paper, which was one of the first reports of using anti-CD47 in humans. There was a company that was formed at Stanford, spun out, and then eventually was sold to Gilead that has this anti-CD47 antibody in the clinic. And what they did here was they just took lymphoma patients who had all seen this antibody called rituximab previously, because it's part of the therapy, but now they were resistant to rituximab, and they just gave them a combination of anti-CD47, this antibody here, and rituximab, and they found about 30% of patients had a complete response. It's pretty good to take patients that were completely resistant to that antibody and then make them have a response again. So I just put on my hat as a pediatric oncologist and someone who exclusively cares for patients with neuroblastoma, and said, well, what's the only antibody we use in pediatric oncology other than rituximab is anti-GD2. So, this is the seminal work from Alice Yu's lab from a randomized trial showing that anti-GD2 prevents relapse in patients with upfront neuroblastoma, and obviously Rajen's amazing work that has revolutionized care of patients that have relapsed or refractory disease when we combine anti-GD2 with chemotherapy. So kind of just building off of that, I said, okay, what if we just combine anti-GD2 and anti-CD47? And so what we did here, you can see we took mice and grafted, these are neuroblastoma cells, human neuroblastoma cells, engrafted right near the kidney. And you can see when we treat with either anti-GD2 alone, we get a little bit of activity at the tumor start, very small. We get no activity from anti-CD47 alone. But when we combine the two antibodies, we get this really high degree of synergy. So the two antibodies work really well together. And this is just quantification. But the important thing is over here, what ends up happening is all of these mice are cured long-term. So you get this great activity where single antibodies don't really give you activity in those models. And then we did the same in some other neuroblastoma models. So this is a metastatic model where the disease goes to the liver and the bone marrow. And here, in line with what we know from studies in children, the antibody actually has some activity when it's located in this disseminated metastatic disease. So you see anti-GD2 does something to control tumor compared to the control over here. anti-CD47 also, but the combination really cures those mice. So, we said, this is great. Is there something special here, or could we have combined any antibody with anti-CD47? So, there are antibodies out there that recognize B7H3 also, such as 8H9 from MSK. This is using a different one. But we said, okay, what if we combine anti-B7H3 antibody with anti-CD47? And we were hoping we were going to see the same great response. But interestingly, there actually was no increased response compared to anti-CD47 alone. And all of these tumors had B7H3 on them. So we said, okay, there must be something really GD2 specific. And we kind of set off to learn what those are. And I'm going to show you them quickly, just because they really affect why, they really color why we think this combination might end up being very effective. So, we already know that anti-GD2 works by engaging the immune system. It has this FC region, this basically flag to macrophages and K cells and even some other types of these white blood cells that says, come and kill me or eat me, basically. But there's also been this thing, this phenomenon reported that people haven't really been able to define or understand, where if a tumor cell has a lot of GD2, even if there's no immune cells around, so if you just put them in a dish and you put them with the antibody, the antibodies, the tumor cells start dying in response to the antibody. So the antibody is doing something by basically signaling to the cell to die just by kind of pulling on GD2. And most antibodies don't do this. So we saw that in the literature, and we confirmed the same thing with our neuroblastoma cell lines that you can see here. Here they're alive without treatment. With GD2, they die. But what was more interesting was we looked at the cells that survived, the ones that didn't die, and those actually had very high levels on their surface of that eat me signal, that stress signal that I talked about, that the cell shuttles to the surface saying, please remove me, when they were treated with anti-GD2. So you see that here in blue, high levels of that of calreticulin in response to treatment with dinutuximab. So this is one reason we think the combination works so well, that the anti-GD2, not only does it tag cells for removal by the immune system, but it also sends a message to the immune system or the macrophages to come in and eat the cells. The next question we had is, could GD2 itself play a role in the immune system? So almost all neuroblastomas express or start off expressing very high levels of GD2, and we never really understood what the function of this is. And generally in nature, if something, especially in cancer, if something's there, the tumor has basically evolved to keep it. And so working with a lab that focuses on basically chemistry and its relationship to the immune system in cancer, we identified, or we looked at these receptors known as Siglec receptors, which basically bind sugars that are expressed by tumor cells. And GD2 is one of the, it's called the sialoglycan, but it's basically just a sugar that coats the tumor cell. And these receptors are expressed on your immune cells. So the immune cells express these, and if these guys sense any of those sugars, they actually inhibit the immune cells. So we said, okay, maybe GD2 is inhibiting immune cells through some of these Siglec receptors. So ultimately, we had to set up a system where we had cells that the only sugar they had on them was GD2. And we screened with these 15 different molecules. And we ended up finding very specifically that Siglec-7 binds GD2. And now Siglec-7 is actually expressed on both NK cells, which are very important in neuroblastoma, and also macrophages, and it's an inhibitory receptor. And then interestingly, by using dinutuximab or anti-GD2, we can block the relationship or the interaction between Siglec-7 on the immune cell and the sugar GD2 on the tumor cell. And so you prevent the inhibition that GD2 usually gives to macrophages. So this tells us that GD2, kind of like anti-CD47, is also a don't eat me signal, this time through a receptor known as Siglec-7 on macrophages. And when we give an anti-GD2 antibody, we drive tumor cell phagocytosis. So just finishing up, when we think about this combination between anti-GD2 and anti-CD47 and this balance between eat me and don't eat me, we're actually really blocking two don't eat me signals, CD47 and the GD2 Siglec-7 relationship. So that starts pushing you towards phagocytosis. The antibody, dinutuximab, provides this FC to the FC receptor on the macrophage, driving more phagocytosis. And then also that signal, that eat-me signal that comes up to the surface in response to the GD2 signaling also drives the macrophage, and you drive squarely towards phagocytosis. So, we are excited that we were able to quickly bring this to a trial, thanks to interest from the company, as well as CTEP, which is part of the National Cancer Institute in the US. We're now open and recruiting. It's a trial, a phase 1 trial of a combination of this same anti-CD47 antibody that's now owned by Gilead with dinutuximab in patients with relapse and refractory neuroblastoma, and also enrolling patients with osteosarcoma. So the trial is very early. We are just treating kind of our first patients right now. And we're happy to report that it'll be open at 13 centers in North America, so between the US and Canada, and about 5 have opened so far. So in conclusion, tilting this balance between eat me and don't eat me signals towards phagocytosis of cancer cells is a promising approach, especially in pediatric cancers. We don't really know, for instance, why Dr. Mody's protocol, the AMBL1221, the combination of chemotherapy plus antibody works well, and the same with the HIT protocol. But I would imagine that it's probably doing the same thing, that it's knocking, it's basically the inflammation that's driven by the chemotherapy is tagging cells for removal by macrophages. And that combined with the anti-GD2, you get this increased effect. So we hope that this combination of anti-GD2 and anti-CD47 will work in children, and we're testing it now in phase 1 clinical trial. Sorry, my computer sorry, and so we're testing it in a phase 1 clinical trial. So I just want to acknowledge first Johanna Therevath from postdoc at Stanford, who has done actually most of this work in partnership with me, and then my lab, Crystal's lab, and then lots of collaborating labs and lots of different organizations who have funded us, including Solving Kids Cancer most recently, to investigate this combination in combination also with chemotherapy. So thank you everyone for tuning in, and I hope this was informative, and I hope to be back in years to come to report on the positive results of the trial.
Thanks, Dr. Majzner, for this really exciting research on anti-CD47 in combination with anti-GD2. So I'm going to invite all the speakers to join back in now, and we've got about half an hour to go through questions from the floor. There's a couple of questions for you, Dr. Mora. The first is it possible for a patient who relapses with ALK while on Naxitamab to attempt Naxitamab treatment again along with an ALK inhibitor?
Yes, certainly. We already have some experience, and it's well tolerated. Basically, we all using lorlatinib, and we've seen patients that are doing fairly well. Still not known whether this is going to be, increasing the efficacy, but certainly it is well tolerated, and we using it. Yes.
Dr. Mody, is anybody administering Chemoimmunotherapy along with ALK inhibitors?
Certainly, I think there is data from COG trial using that, and we have anecdotally used in our patients. Immunotherapy alone with ALK inhibitor and chemoimmunotherapy with ALK inhibitor, both the first generation crizotinib as well as lorlatinib.
Thank you. There's another question for you, Dr. Mora. With so many new centers administering Naxitamab, can you speak to the training safety protocols required to make sure that it's given safely?
Yes, indeed, this is really important. We've gone through different ways of approaching these. Prior to the pandemics, all the teams were supposed to either go to New York or to our center, and things really worked well. But the pandemics prevented this mode, and so we had to go through different ways of online training, which didn't work that well, I have to say. It's basically because hands-on and having the nursing team as well as the anesthesiologist and the oncologist used to manage these very intense reactions, although transient but intense. They have to really be prepared for that, and usually centers that are not used to anti-GD2 antibodies, they tend to overreact, and patients do not really benefit from what it is supposed to be. So I'm really hoping that the post-pandemic world will be able to go back to the real training of the new teams, and things will become smoother again.
Thank you. So I'm going to ask the next one to everybody. Let me start with you, Dr. Mody. So all presenters, has any work been done to establish the maximum cycles of immunotherapy/chemoimmunotherapy that patient can receive? Is there a lifetime limit? Should families limit cycles for the future to assure their child has options for the future?
Yeah, so that's a great questions, and I think we are all kind of struggling with that. As I presented and talked about, anecdotally, patients have been treated on ANBL 1221, which allowed 17 cycles, and we had 5 patients complete all 17 cycles. And in an event of progression, they have used second, third, and fourth time with different chemo. And I am aware of at least patients receiving upwards of 24 cycles. There is a considerable debate at the COG community that what is the maximum cycle. Nobody truly knows the evidence-based answer, but there is the newer COG studies which are going to use chemoimmunotherapy cassette are going to limit to 8 cycles. Patients who do not respond by the first 6 to 8 cycles, they're unlikely to benefit. And if patients are responding and they go into remission beyond 8 cycle, they need to be consolidated with some other therapy. So there is a debate going on. Unfortunately, we don't know the answer. I do know anecdotally patients who have received 24 cycles with different chemo combinations and has tolerated it well without any side effects.
Thank you.
Well, in our opinion, I think immunotherapy and chemoimmuno have significant roles, but the goal. So we have to establish the goals, right? What are we using the anti-GD2 immunotherapy for? So for first CR patients, we're using it to prevent relapses, right? So control MRD, and this we have. Well, the New York group has already shown that that can be achieved with the bivalent vaccine. So our program is now to build the anti-GD2, anti-idiotype network for the patient in the long term. So we are using 5 cycles in complete remission for all patients who achieve complete remission, and then they move on to the vaccine. Vaccine is well tolerated. There's no pain induced. The anti-GD2 antibodies, native anti-GD2 antibodies generated are higher than actual antibodies and persist longer in the body. So we are aiming for long-term anti-GD2 vaccine program for all survivor patients.
Thank you.
And I'll just add.
Yes, please, sir.
Taking care of patients also, many patients who have, second, third remissions with 1221 based therapy, that it's generally unclear how long those patients should be treated for. Or a patient who has a local relapse and you induce a remission with surgery, should they get antibody alone or should they get chemoimmunotherapy? And none of this has been shown to increase survival in any way yet. I'm sorry, what I should say is we don't know the effects on survival of extending the treatment of 1221 yet. And these are all questions that really can only be answered in randomized trials. And I'll point out that likewise, the question of a vaccine preventing relapse in patients with first remission or second remission or later can only be answered in the context of a randomized trial. Ganglioside vaccines were tested in many patients with melanoma and had positive results in phase 2 trials and then ultimately failed in phase 3. That doesn't say that the bivalent vaccine that's being tested is not going to be effective, but we don't know until there's a randomized control trial.
Thank you. There's a question about vaccine availability, Dr. Mora, and it's specifically, is the vaccine available in Barcelona at the moment? And is
Not
there
right now. We are opening the trial in the next few months, coming months, and talking. Going back to Robbie's comment, fully agreed. And actually, I am aware that COG and both and PSYOP are already in conversations with YMAPs in order to arrange for this necessary randomized trial, but that will eventually have to be through these large cooperative groups. So definitely it has to be done, and hopefully will be done. But in the meantime, and for the interest of learning more, the phase 2 trials will be open in New York and in our center, just to answer different scientific questions on how these anti-IgG networks work and whether that will correlate with future preventing future relapse and so on and so forth. But large cooperative studies will take time to get ongoing. So in the meantime, we will have these limited centers studies going.
Thank you. So I'll put this question in. This is a question from Dr. Majzner to you, Dr. Mora. Have you seen any patients on the HITS protocol who have previously progressed on dinutuximab with irinotecan and temozolomide?
Well, no. I'm in the EU, and as opposed to the US, things move much slower. Chemoimmuno, it's only being recently initiated here by different groups, and so there's no such large experience or long time experience like in the US. So very few patients worldwide have, first of all, access to antibody at all. And even in Western Europe, chemoimmuno with dinutuximab beta is only being started to be used now. So no, the answer is no.
Thank you. So here's a question relating to Europe as well. The role of GM-CSF, which generally within the CIAPN group isn't used because it's not widely available within Europe. What's your thoughts on how important GM-CSF is with...
Well, my colleagues from COG should answer this. They have developed all the data that fully supports the use of anti-GD2 antibodies. So nobody in the US, and I follow the standards in the US, would ever use anti-GD2 antibody without GM-CSF. So the question speaks by itself. The data is fairly clear in the lab that GM really potentiates the response. And so I have no question that this is really necessary. The problem is that, like the antibodies, if you don't have it available, you will like to claim that it's not necessary. I don't think that's the case.
So yeah, I mean, there's a difference between whether it is a benefit and whether it's available. So, Dr. Majzner?
I'll just say, I mean, the science is unclear in that the preclinical work is really tested either, I mean, it's mostly done in vitro, but even when we test it in NSG, in immunocompromised mice, it's unclear. This question has never been answered in a, again, a randomized fashion to know whether the GM-CSF adds or not. I will say personally, I've had some patients that have been, multiply relapsed neuroblastoma patients receiving 1221 or other combinations of chemotherapy plus antibody, and the parents have chosen not to use GM-CSF, and we've still seen responses with G-CSF used for support. Now, that doesn't mean that GM-CSF wouldn't add to the efficacy. It doesn't mean that GM-CSF doesn't support single agent, dinutuximab or naxitamab. We just don't know the answer until we do clinical trials.
Yeah, and I would second that. I think just remember, I think the IL-2, once upon a time, I think, IL-2 and its all activity on the NK cell, it used to be considered indispensable in this cassette, and has silently, at least on the North America side, has fallen off without any real detriment on its response rate or survival. And so I think unless we do randomized trial, we have had, unlike Robbie, I don't think we necessarily use it 1221 without GM, but we have had patients who, as you guys know, with GM, sometimes you have severe hives or allergic reactions or all of the other things that people have noticed to leukine. We have had patients to stop it and then not give it in subsequent course with responses. So we certainly have anecdotal data of few patients without GM still responding. So clearly, unless you randomize patients, we would not know the answer.
And I just want to add, just because you would find out from a randomized trial doesn't mean it's worth doing a randomized trial.
No.
We have limited patients, limited resources, and the best is to test newer or innovative. I mean, I guess everyone makes a decision what's best, but I think we want to test newer or innovative drugs. So sometimes, it's not that harmful, even if it doesn't support, but there is a rationale for it supporting.
Thank you. So I'm going to ask this question to Dr. Mora, and then I'll come to the other panelists for a follow-up. Dr. Mora, in the cases you mentioned that are considered stable but are differentiated, how are they reported officially in study results?
No, well, that's exactly the point. For study result reporting, we all use the same, mostly the same criteria, and so those patients would be considered stable disease, basically non-progressing, image-based analysis by MIBG standard. So that would be considered stable disease. But when you look further and you go deeper into the details, then you find out that indeed in chemoimmunotherapy and even immunotherapy alone can induce differentiation, which also that was shown a long time ago by chemotherapy sometimes. But so the issue here is that what the standard criteria that we use, we are underestimating the results, actually, the benefit for our patients. And we should be looking a little further beyond the standard imaging techniques that we are using in our trials. That was the point.
So can I just ask the other guests if they see similar experiences with 1221, maybe in some of those patients who have very prolonged administration, and are they followed up with PET scans in the event that MIBG remains stable?
So I can, Robbie, you wanted to go? I can answer that.
No, you go. I'll follow up.
Yeah. So we have had patients on 1221, and in fact, on our study, we had 22% of patients who actually, 22 patients, which accounts for about 42% of patients who had prolonged stable disease. And we have followed many of these patients with PET. Many of those stable patients, unfortunately, do ultimately end up progressing. So this differentiated, I can say that anecdotally, I know of 2 patients who actually remain differentiated and never progressed, but majority of patients, unfortunately, with stable disease do end up progressing.
And I'll just say, yeah, we see it also. There are some patients that have differentiated disease, but I also, when I came to Stanford, I inherited a lot of neuroblastoma follow-up patients, patients that are 7 years out from therapy, got a lot of retinoids, got anti-GD2, but never even saw 1221. They've got an MIBG score of Curie score of 9, a mixed picture in their PET. The PET's not completely negative. I agree with you, Dr. Mora. PETs are wonderful to look if the patient is likely to have progression, but there are times that it's still positive, and somehow the patient hasn't progressed. And like Dr. Mody said, I think everyone lives with this fear that it may one day progress. We really don't know, and better imaging and better understanding of this biology would, really, I think, change the trajectory for this group of patients that have persistent disease or persistent imaging findings.
Okay, thank you. So next question, kind of for everyone. At what point would you recommend a patient switch from dinutuximab to naxitamab, or vice versa, with or without chemotherapy, in relation to how they are responding to treatment? Don't know who wants to take that one first. I mean, would you recommend changing antibody? Other circumstances in which?
Well, we've seen cases not responding to chimeric antibodies, and they do respond to naxitamab. But I think both antibodies are different in many ways. So that's potentially it can happen. I don't know whether there should be any rule for that. We are all looking for getting our patients into complete remission. So you better use whatever you have available. Again, I think this is a very limited perspective. Majority of the children with neuroblastoma in the world have no access to any antibody, basically. So it's the point is not whether we should switch to one to another. The major issue is how can we arrange for every child to have access to any anti-GD2 antibody, whatever it is. It's better anyone than none. And we all agree on that. So we should be looking forward to have all children with what we call standard therapy. The rest is anecdotal to me.
Yeah, I agree.
Yeah, I don't think anyone could argue that every child.
Yeah, I think the only point I will again make, I think Robbie said that earlier, but that we have to be very careful, kind of extrapolating data from one antibody versus unless there is a randomized trial done, and especially naxitamab versus dinutuximab, as I actually tried to make it clear in my talk, that most of this chemoimmunotherapy response rate and survival data are for patients who actually had a bone and bone marrow disease, as well as many times large soft tissue masses. And so we have to be very careful comparing that to actually an evaluable patients on many of the naxitamab trial. And I'm intimately, because of my role, I'm intimately familiar with naxitamab data, so I don't need any more data actually, but we have to be very careful unless there is a trial done. And so that's why I think I don't want, just like Dr. Mora said, like jumping from one antibody to another in hope. But there is a chimeric antibody. If you have an adverse reaction and intolerance, maybe there is a merit to go to a humanized antibody because of intolerance. That maybe makes scientific sense, but otherwise for efficacy purposes, jumping antibody, I am not sure is probably any one of us would endorse.
Well, if you developed the antibodies against either the chimeric or the human antibody, would that be a justification for moving across as well?
If you have HACA with chimeric, that would be one of the patients, one of the reasons to consider other humanized antibody.
Rajen, do you know that if patients have HACA and get 1221, that they don't have responses? Do we know that?
So we do know that they're effective. Paul Sondal has the data where their efficacy is lower, whether they do not complete it, but we do know that it's cleared quickly, and we have a data on 4 patients that their response is very suboptimal responses.
And
the reason to bring that up, and I think it actually brings it to a different point, a slightly different point, is in our trial we had done dinutuximab levels and dinutuximab peak and trough levels, and I think we found that higher dinutuximab trough were associated with better responses to chemoimmunotherapy combinations. And when you have HACA and the antibodies cleared fast, then you're likely to respond less. Again, would I make a definitive statement based on 4 patients? Absolutely not. But I think there is, and I think that's why in the newer, Robbie in the front COG study, some of the PK studies with dinutuximab are planned. So we probably will know the answer with more certainty.
So I'll just add, I wanted to echo what Rajen said about randomized trials. I think there could be a role for using multiple GD2 antibodies. We just don't know them without doing the trials. For a variety of reasons, those trials aren't getting done. If we really think that we have a game-changing or an agent that could dramatically alter the outcomes for patients with neuroblastoma, we need to do those trials, and we need to make them happen in a way that's scientifically rational and feasible across the world.
Thank you. Let's move on. We've got about 10 more minutes. Is any research being conducted on optimizing the chemotherapy dose and timing in relation to chemoimmunotherapy? I don't know if anybody wants to.
Yeah, again, I would just go back to what Robbie just said. This COG looked at the St. Jude's data and said St. Jude's have now showed you one way of doing things with their humanized antibody. It's a single institution. In order to truly extrapolate whether anything different is more powerful or safer, that's why we need a randomized trial in a multiple centers, and so that trial is being designed right now. In terms of sequence of chemotherapy with antibody, I don't think people have tried different sequences and things, but I think currently the way it is given concurrently, and that is what is planned for the next trial.
Well, my answer would be we don't know the mechanism by which combinations work. So unless we get the help of Robbie's and work and others to understand what magic part is, we will then be able to combine it better with other, and the drugs and the type of drugs and the doses of the drugs will be able to play around with. Otherwise, we are completely blinded. This is all empirical findings that we've made, and we keep doing it blindly, basically.
Yeah, completely agree. Yeah.
As a question for you, Dr. Majzner, the parent community have very high expectations of the new trial. Any early results? I think I'm going to know the answer to this, but I'll pose it to you anyway. When would you hope to have results?
First of all, I don't get the results because it's done centrally through the CTEP coordinating center, but I think one patient has gotten the combination for 1 week, so I really have no results. So we also are hopeful, but I caution it is a phase 1 trial. We're honest about this. You can only be honest about the science. It's in mice. We have a rationale for bringing it to humans. We don't for children. We want it to be successful. We don't know yet how successful it will be. But we're hopeful, and then hopeful to add it on to a chemo backbone also in the future with support from SKC, but building on the work of the other panelists.
Thank you. Just a question here. I don't know if anybody has any thoughts on the work from Dr. Loder's group. He published 2 patients with PD-1 inhibitor with dinutuximab beta. Don't know if anybody has any views. It says. Would anybody consider it in combination with irinotecan temozolomide?
Well, we all had, I'm sure, anecdotal experiences with that. Basically, what we all trying to do is when the patient do not respond, we biopsy the lesions, and try to identify markers that can guide your rescue treatment. And anecdotally, you find very rare cases whereby there is an increased expression of PD-1 or PD-L1 in the tumor, even in neuroblastoma. So we've had a few very, very rare cases whereby we have added anti-PD-1 treatment on the rescue management. But again, we don't know why those cases, do respond using this checkpoint system. Similarly, that we don't really know and understand why anti-GD2 and chemoimmunotherapy really work. So we need to learn much more on the mechanisms before we keep advising on doing things.
Thank you. Quick question here, Dr. Mody. Long-term effects from anti-GD2. Is there a clear view on the expected side effects, particularly in those patients that have prolonged administration?
Yeah, so that's a great question. Again, something that only with coming time we will know, but we do know that we at least have a 10 plus years of experience with chimeric. There's a longer experience with 3F8, and so I would say our institution is currently doing a long-term survivor study. Unfortunately, we still with all the successes, the number of survivors are still pretty small. COG and Lisa Diller's group is looking at it. We have our single institution study. But I think a brief answer is I think there are patients who develop acute toxicity with sometimes motor paralysis and others. But other than that, patients who have not had any other toxicity other than pain or eye toxicity, majority of the toxicity resolves. And we are doing some neuroconduction studies and some of the other studies to understand whether there is any long-lasting effect. So far, I can't say that we have seen a lot of long-term toxicity with this agent.
The longest experience from the Mura 3F8 from New York, it's more than 20 years now, and there are the long-term survivors have 0 side effects from the anti-GD2 antibody. So that is very well known. Our patients have a lot of side effects, potential and actual long-term side effects from chemo, from high-dose chemo, from radiation, even from surgery, but not from anti-GD2 antibodies.
Thank you very much, Dr. Majzner. I'm going to roll 3 questions up here for you. Does the combination, in your view, does the combination of anti-GD2 and anti-CD47 have the potential to become a breakthrough in neuroblastoma? When do you expect that anti-GD2, CD47 and chemoimmunotherapy will be available on trial to children? And how do we move this research forward faster? Can you collaborate on a larger multi-center trial that would accrue patients more quickly?
Sure. These are all great questions. Is it going to be the next breakthrough? Obviously, would love for it to be, or for anything out there, even anti-PD-1 to be the next breakthrough. We just want to get new therapies for children. It's very hard to predict with phase 1 trials what's going to be successful and what's not going to be. So I don't want to opine on, on the likelihood. I think most phase 1 trials don't end up as breakthroughs, even when they're very scientifically rational. That's not to say I'm not hopeful about the trial. The next question is, when will anti-GD2 plus 47 plus chemo be available? So currently there's no label for anti-CD47 in any country in the world. The most advanced is the agent that we'll be testing and is going to go into a registrational trial in adults with MDS and with leukemias. So because of that, it's not available outside of a clinical trial. So we can't just say we're going to add, okay, we'll try it next like PD-1, we'll try it next with chemotherapy as long as we can get the agent, because we can't get the agent. So for now, it's going to be studied anti-GD2 and anti-CD47 alone. And that was by design because the toxicities of anti-CD47 are unknown in kids. And while we expect it to be safe, there's also potential toxicity combining something that unleashes macrophages with an antibody that recognizes normal nerve cells. Now, we haven't seen toxicity in mouse models, but they don't always predict toxicity in humans. For instance, the mice don't seem to have a pain syndrome at all. So it's just a long way of saying we need to finish this phase 1 trial. And then if there's a signal of activity, we will quickly try to combine with chemotherapy. While we're doing this phase 1 trial with the support of Solving Kids Cancer through a collaboration with Dr. John Anderson's lab in the UK, we have kind of a transatlantic collaboration looking in preclinical models to understand chemoimmunotherapy plus anti-CD47. And that type of funding, putting it together and doing the preclinical studies while we're doing the phase 1 is really going to help, I hope, accelerate that we'll be able to add chemotherapy quickly if if it's safe and we have an efficacy signal. I think these types of grants or programs that drive cross Atlantic, but also, obviously should also be cross Pacific and worldwide collaboration to get these trials done are really, really important. It's heartbreaking to know that patients, even just anti-GD2 is available to patients in the US and Europe and not available to patients in many countries in Asia.
So I'm gonna ask this one last question and then draw the session to a close, and that's probably a good link into it. How are we going to reduce the costs for anti-GD2 antibody therapy? How will it ever be possible for children in low and middle income countries to access this therapy, if not?
We're the wrong people to ask to.
I completely agree with that. It's the wrong audience. And
however, I have to say that YMAP Therapeutics was created by the parent of a child who survived neuroblastoma and CNS relapse. And the commitment of the company is to make it available to as many children as possible, and to through and getting into most reasonable price possible. So we'll have to see whether the company is up to what they claim to say.
So this is really a task maybe more for people like me and advocates in the field, right, to take that one on. But just to finish, for countries which maybe don't have the same levels of supportive care, is it a realistic aspiration to be delivering Naxitamab Chemoimmunotherapy or Naxitamab in those settings? Or do we need
I think in a lot of I guess there's low income and middle income, right? In low income countries, it's probably not currently feasible to treat patients with high dose induction chemotherapy in many of those countries, or it's not being done in many of those countries. It's just like a huge barrier that is not restricted to anti-GD2 is a huge problem that we have. Obviously, if we could bring those patients to Western countries to be treated, it would be wonderful. With the health system in the US, that's basically an impossible feat.
Right, I think that's a good point. Anti-GD2 antibodies are part of a multimodality treatment to cure a high-risk neuroblastoma patients. So we need to make sure that patients get access to intensive chemotherapy appropriately performed, best surgery possible, radiation, as well as immunotherapy. So there's a lot that is required to cure a high-risk neuroblastoma patient. It is very hard in advanced countries, nonetheless. So there's a lot to improve in many parts of the world before claiming for anti-GD2 antibodies.
And on that note, I will draw. Sorry, Dr. Mody.
No, I would just say that what I think one of my co-speakers mentioned, I don't know who mentioned that, but there is a great role from parents and advocates when you talk about the drug cost. We all know the cases and the story of the AIDS advocate and what some of the Africa and patients in Africa and India and how they were able to get drugs. And so the advocacy, don't underestimate the power of advocacy, I would say. And that's probably the best way to ultimately get some drugs. But otherwise, I do actually, not only I grew up and practiced oncology in India, but I think I go back for the last 10 years, except for this last 2 years, and work with cancer centers there. And I think what my co-speaker said, I would probably agree with that not only antibodies are a problem, but sometimes supportive care after the high-dose chemotherapy is a problem. And so people even don't have access to a basic, some of the standard of care. So to bring the experimental agent is also even more difficult. But I don't think we should not lose hope. This is not to say that we should give up. I think we should just do it in a steady manner, and I think ultimately keep advocating for getting better and effective therapy for all children.
I'm sure we all echo that. Gentlemen, thank you very much for your time today. It's been a pleasure to spend this session with you all, and I will draw it to a close there. Thanks, everyone. Thank you again to all our speakers. Up next at 7:40 GMT is our survivorship session featuring neuroblastoma survivors John and Julia, so stay right where you are. Remember, if you missed this session, you can watch it on demand on the event platform. Thanks very much.